Corso is known for her research in economic evaluation and economic impact assessment, primarily in the areas of child maltreatment and substance use prevention. From 1991 to 2006, she conducted health economics research for public health interventions at the Centers for Disease Control and Prevention. In 2006, Dr. Corso joined the faculty at UGA as the first founding head of the Department of Education Policy and Management. She holds a master's degree in public administration from UGA and a doctor's degree in health policy from Harvard University.
Thank you so much to the Coalition for inviting me and for Max, I think, put in a good word. I'm really excited to talk to you today a little bit about the research that my team does and to give you an example of where we're using economic evidence to inform the policymaking process. So let me just start off with the definition. So we talked about economic analysis, we talked about returns on investment analysis, Max use the term benefit cost analysis. This kind of fits all under the umbrella of economic evaluation. And when I use this term, I'm really talking about applied analytic tools to help us identify what are the things that we care about, whether it's in education or in health or in criminal justice. What are some of the prevention strategies to deal with those things that we care about? How do we measure the outcomes of our interventions and our programs and our policies? And how do we put a value on what those outcomes are? And then once we're able to put values on those outcomes, how do we compare one intervention to another? So I think Max gave some really good examples of where just having a prevention strategy might not be enough. We need to know whether there's an evidence base behind that prevention strategy. And then I say take it to the next step and let's find out whether there's an economic evidence base. And that's really what we're talking about in economic evaluation. I come from the field of public health, so most of the examples I'll be sharing with you today are health related. And I will tell you that in the treatment world for healthcare, economic evaluation is part and parcel of what they're doing in treatment. If you work for a pharmaceutical firm, you're looking at the cost effectiveness of your drugs before they go into the marketplace. If we're looking at new medical devices that are going to be considered, we're looking at the cost effectiveness of these devices. In public health, we're a little bit farther behind, but we've seen some great strides in the last couple of decades. So why should we care about the economics within the context of evaluating our interventions? Well, first and foremost, as a public health practitioner, I would argue that maximizing outcomes is our most important goal. Same thing if you're coming from the education field, we care about improvements in educational outcomes, we care about graduation rates, and so those are the things that we strive for the most. But second to that is that we have to be very careful with how much money we're spending, right? I think we're preaching to the choir in this room. But because we have scarce resources, we have to make some hard resource allocation decisions, and so that's where economic evidence plays a major role. And when we look at economic evaluation, we're demonstrating the value provided for the resources that are expended. That's for every dollar I spend, I save $2. And we keep using this term returns on investment, although I do want to clarify what exactly returns on investment means. But I want to first say that economic evaluation is not the same thing as the field of economics. Economics is more closely tied to explaining choices of individual behavior, whereas economic evaluation is really looking at what are some of the tools that we can use to help the policymaking process. And so that's why it's a very appropriate tool for us to be using in the context here today, where you all are policymakers or you're working for federal agencies who are setting policy, and economic evaluation plays a major role here. When I use the term economic evaluation, I'm referring to several different types of methodology. Partial economic evaluation is where we're concerned with costs only. This is very important, but more in the nascent stage of analysis. The first type being economic impact analysis or economic burden estimates. In health, we often call this cost of illness analysis. I worked at CDC for about 15 years, and I will tell you that within each organization I've worked at CDC, the first thing they wanted to know was how much does our thing cost? How much do injuries cost the country every year? How much is obesity? And this is what we hear in the media every day. Childhood obesity is a very important problem. The morbidity is this, the mortality is this, and then the economic burden is another very important component. So this is really the first step in thinking about the issues that we care about. From there we go to programmatic cost analysis, or cost analysis, sometimes is without using the word program, because this is where we're looking at the cost of our interventions, our policies, or our programs. This, I believe, is the first step in an economic evaluation, where oftentimes programs or interventions think they know how much it costs to run their program because they have a budget in front of them. But from an economics perspective, we know that that is not what it costs to run an intervention. There are many resources that go into running a program that don't show up in your budget that we would want to account for in an economic sense, because we want to know all of the resources that are required to run an intervention and put a value on that, whether they're on the budget or not. Very time-consuming, tedious step in economic evaluation, and there isn't a lot of guidance, unfortunately, out there in the literature on how to do programmatic cost analysis. Although certainly this coalition and the Society for Prevention Research are trying to come up with better guidance for the field. From there, we move to full economic evaluation. The first type is benefit cost analysis or cost benefit analysis. These terms are used interchangeably in the field. This is where we look at the cost of our programs and we compare them to the dollar value of the outcomes of our program. So everything is in dollars. The subset of cost benefit analysis is returns on investment analysis, this term that Max has been using, and we also think about budgetary impact analysis. And to me, there's a very important distinction here. The question that the gentleman asked in the front row about do you consider negative externalities or some externalities associated with your intervention, I would argue that benefit cost analysis is the larger umbrella here, where we would look at all costs and benefits of the program or intervention, regardless to whom they accrue and regardless when they occur. So it is very much from a societal perspective and from the policy-making or government perspective, it's really one we should be thinking about the most, benefit cost analysis. Returns on investment analysis comes from the field of business or marketing, where people have a shorter time frame, where businesses are putting money in to a particular project and they want to know how long before they see the returns, the real bottom line returns on that investment over a short period of time. We have taken on this term returns on investment in the field of prevention and the field of public health, but at least from my academic perspective, I see this as more narrowly defined. So I would just caution us in using that term. Budgetary impact analysis is looking specifically at the impacts of our programs and policies on our budgets, particularly our government budgets. And this is also an important thing we should be looking at as well. So thinking about the Affordable Care Act as an example, lots of policies in place around the Affordable Care Act. What kinds of impacts might you have on the Medicare budget or the Medicaid budget based on some of those policies? So very narrowly defined to government budgets. In public health, we don't always use benefit cost analysis as the type of methodology we use in economic evaluation. Sometimes we use cost effectiveness analysis. And in this case, we look at our program costs in dollars, but we compare our program outcomes in the natural units that are being evaluated in prevention. So for example, if we're looking at a breast cancer screening program and we're looking at the number of cases prevented for one type of screening program versus another, we don't have to convert cases prevented into dollars in a benefit cost, as you would in a benefit cost analysis. In cost effectiveness analysis, we keep our natural units as they were, which is cost per case prevented. But you can see from a policymaking perspective, this may prevent you from comparing one type of program to another if it's the case that your natural units are different. And so benefit cost analysis, again, is more the gold standard for economic evaluation because you can compare across programs. But if you're down at the micro level of evaluation, then cost effectiveness may be the place to go. I also threw up this term cost utility analysis, although it's not being used very much in the literature anymore. But it's a specific type of cost effectiveness analysis that looks at survival and quality of life as your outcome measures, combined into a health index, oftentimes called a QALY or a quality adjusted life year, if you're familiar with that term. And so where does economic evaluation fit within the context of the prevention model? And I call this a public health model for prevention. Again, in my experience at CDC, when I first went to work for the Division of Violence Prevention, the first thing they asked me to do is assess the cost of violence in the United States. And that is the cost of illness right there. So this really fits into the area of prevention called problem identification. What is the morbidity? What is the mortality? What is the economic burden? But once you have that information on the outcome that you care about, again, this is applied to public health, but you can apply it to education or other fields as well. But you want to then learn about what are your risk and protective factors to deal with this issue. So you think about epidemiologists and statisticians, and those are the types of people who are fitting in those top two boxes. This is a theoretical model, so once you learn about risk and protective factors, that then allows you to redefine your problem perhaps a little bit more broadly if you've determined that there are more risk and protective factors. From there you go into program and policy development, again, being driven by the risk and protective factor information. In program and policy development is where we assess how much our program costs, how much our programs cost. This can be done alongside program development and policy development, and in fact, if you want to think about broad implementation and dissemination in the future, you should be keeping very good tracks of your program costs. Back to the question raised earlier about how do we use our administrative databases to do economic evaluation, one thing that I would argue is that you can set up your administrative databases to closely monitor program costs, and program costs down at the unit level. So if it's family served or child served, you enhance your administrative databases for you to track those costs a little bit more carefully. Once you've developed your program, then you go out into program and policy evaluation. So you see efficacy trials. In this area, we see large-scale effectiveness trials as well. And typically, in this model, straight from efficacy and effectiveness, we go out into broad implementation and dissemination. And again, this is a theoretical model, so all this should feed back to enhance your program development in the future. I would argue strongly that before any program goes out into broad implementation and dissemination, that there should be some evidence of cost effectiveness or benefit cost analysis, which is why I have economic evaluation between evaluation and dissemination. This is my ideal world, my theoretical model. I'm sure the rest of the world is following this. So this is one of my favorite slides in trying to explain what type of economic evaluation one might do depending upon what policy questions you need answers, or what policymakers are asking the questions, maybe another way to phrase it. So if you're sitting at the very macro level of policy and you're trying to make decisions between defense and health and education, benefit cost analysis is probably the most appropriate type of economic evaluation to do because everything's converted into dollars. So returns on investment analysis, again, maybe from a more narrowly defined perspective, would also fit into this realm. But if you're at the micro level of decision making, so thinking about sitting in a local health department and you're trying to think through what types of medications you should be providing in your STD clinic, for example, your goal there is reduction in cases of disease. So you don't necessarily need to translate cases of disease prevented into dollars. You can keep them in your natural units and do your cost effectiveness analysis. And then cost utility analysis, as I said before, is a hybrid cost effectiveness analysis where you're using multiple natural units. All right, so when I talked to Max about what example that I would share with you today, I have been very fortunate to do many different types of economic evaluations and have been funded by several federal agencies to do that. But I chose an example that's never going to see the light of day. So this is kind of the one study that you do in the back room, and you hand it to someone and you hope it impacts policy. And I think it's impacted policy, but I can't say it's all of what we've done that has impacted the policy. But this is never going to be in a peer-reviewed paper. That's not what we were asked to do here. As an academic, I think a lot of people think academics only do research to get published, and I'm here to show you that there's at least one thing we've done that's never going to get published, and we're okay with that because we think we've impacted policy. So this is really important work. So in January of 2012, we were approached by the Children's Healthcare of Atlanta and the Marcus Institute, which deals with autism and other disorders for children, to help them think through how they could influence a discussion around whether Georgia, and in particular the state health benefits, should cover autism as part of their health insurance policy. I imagine that this comes up in states all over, has come up in states all over the country. If not this issue, then a very similar issue of what should be covered under health insurance. Children's Healthcare of Atlanta is a very strong and powerful group in Georgia, and is a champion for anything related to children's issues. So we were pretty excited to be approached by them. Basically, this is the background of what they wanted us to do for them. So in 2012, the policy that was under consideration was a mandate requiring therapy for autism spectrum disorder be covered by insurers. And our goal for CHOA was to estimate the costs that would occur to the Georgia State Employee Health Benefits Plan if such a mandate were in place. And the primary costs for dealing with kids with autism is applied behavior analysis. And I just want to mention this as an evidence-based therapy for autism. So again, they're not asking us to look at any prevention intervention. They're asking us to look at something that has an evidence base behind it. And so we were asked to consider 3 different insurance benefit scenarios. One where there would be one that's at the minimum level, where there would be an annual cap of $36,000, and it would apply for kids age 0 to 10 years. And just, I don't know that much about this therapy, but I will tell you that the sooner you get these kids into therapy, the better off. So that's why you see these ages from 0 to 10. If you started this therapy at age 10, you went from age 10 to 21, the effectiveness of the therapy is much diminished. So you really want to get these kids early. And then you can see we were looking at the middle scenario here, where it had a higher cap and a longer time period for kids to be in therapy, and then we had a maximum scenario. So here's what we did for them. This is a horrible slide, right? But I thought if anybody asks, like, where'd you get your data? At least I've got a slide available for you. But just to show you, when you do any type of analysis like this, there's no one perfect database that is handed to you for you to do your analyses. It just doesn't work that way. And so we had to go to several different sources, including the literature and the gray literature. Again, people who've done these same kinds of analyses for their states, we would call them up and say, can we have your data? And so we did the best that we could with the sources that you see here. Our methodology was to look at the total number of covered lives under the Georgia State Health Benefit Plan. And we wanted to look at the number of covered lives by age. Again, that would help us know what kids would be eligible for the therapy, applying the autism prevalence rate in Georgia. And then we looked at the average number of annual therapy hours and the average hourly rate for therapy. And again, we were able to get this from another state that had done a similar analysis. We would sum the cost of all the therapy across ages, and then we would add appropriate insurance administration costs, because anytime that you add a new benefit, there are more claims that get submitted, so there has to be some cost for administration. And then we compared the increase in costs, the current total premiums that were paid, to determine how much the premiums would have to increase for all members in the plan in order for this benefit to be covered at the 3 levels that I showed you on the previous slide. And here are our results. For the minimum scenario, that's $4.2 million, which results in a 0.17% increase in premiums, all the way up to the maximum scenario, which is $5.9 million, at a 0.24% increase. And the bottom line what this means is that for the average premium for the folks that were in this state plan of $3,600 a year, they would be adding $7.50 for the middle scenario. And then the lower scenario was maybe like $6, and the higher scenario was maybe $8.50 or close to $9, just so you can see what the range was. So how do we compare this to the benefits? So this really speaks to the point that was made earlier about sometimes in our prevention programs, the person who pays is not the person who receives the benefit. And again, this is why I would argue a societal perspective really matters, because we should all be in this for the greater good, which is including all costs and benefits regardless to whom they accrue. But let's just look at what kind of benefits would come with this therapy. So most kids with autism require special education services if they end up in the school system. And special education, while it may have some incredible impacts for some children, has not been shown to be effective for most kids with autism. So there's no evidence base behind just having kids go into special education. And not only that, but special education is very expensive. Now, if special education savings for children that have received therapy before they end up in school, so again, that very critical time of 0 to 5 years before they end up in the school system, is estimated to be between $200,000 and $300,000. Again, we got this from the source you can see mentioned there. In addition to that, the lifetime savings from therapy have been estimated at close to $1 million, getting kids in therapy between the ages of 0 and 5. And this is not just reductions in special education costs, but it's also everything else that is focused around kids getting the right therapy early on, like home and community-based services, reductions in institutional services, Medicaid waivers, supported work services, etc.
Yes, so those are the savings to Georgia's government or to anybody?
This right here comes from the literature, so this is to anybody. And this is for kids who are receiving therapy in the time period that they need to receive the therapy. So, yeah. So when you look at those potential benefits relative to the cost that we estimated for our legislature, you can see, I've highlighted here in red, just so we can get to the main point, that the costs are $194,000 for therapies per student that mainstreams. And there's some, there's some caveats in here too, right? Not all kids with therapy are going to be 100% effective in that therapy. Not all kids who come into the school system are going to be mainstream. Some will still end up getting special education. Not all kids will receive the four therapy sessions per week. So we have some of those assumptions built into these calculations. But for those kids who do mainstream, the costs are $194,000, and the savings, and this is Georgia savings, are $200,000 to $300,000 per student. Now that's just in the short term. That doesn't include what the long-term benefits are for these kids because they've received therapy. And so that's where this bottom line comes in. So this is a pretty powerful argument for your state legislature, right? So we're happy to say that a couple of weeks ago, our governor signed into law what's called Ava's Law. So this is an effort that was led by Anna Bullard, who was a mother who struggled to pay for therapy for her daughter, Ava. I wanted to show you the Senate and House votes because these are really nice looking votes, right? Do you see those very much here? So we were behind the rest of many states, I will admit. We're the 41st state to enact the autism insurance reform. But the interesting thing here is that our study looked at the benefits to the state plan only, but the law is for all insurers in the state. So it actually is, even though the cap here is not as generous as what it could have been according to our calculations, at least it applies to all the employers in the state. So I think this is a pretty good example of where economic evidence can inform the policymaking process. So with that, I will say thank you, and I'm very glad to take any questions or comments from you.